Hi all, I am Dr. Nithin, a senior consultant from DentoCrest. I'll be the one doing the MC for today. So today the webinar is on monitoring clinical outcomes in dental practice, and the uh, uh, program is being spoken by Dr. Charubala Pavan, and the program director is Mr. Dr. Arjun KR. I would give a brief introduction of the moderator and the speaker, and then over to Madam. Yeah, about DentoCrest and basically Dr. Arjun KR has completed his BDS in the year 2005, completed his Masters in Hospital Administration in the year 2009, and about DentoCrest, it was started in the year 2016 and is based in Bangalore. We are specialized in offering quality management consultancy services for dental facilities. We have over 100 plus dental facilities across India who have obtained prestigious NABH or QI accreditation. He's an associate, and we are associate members of AHPI. And about Madam Dr. Charubala Pavan. Madam is a versatile oral health professional with experience in diverse fields like quality in healthcare, public health, and clinical practice as a dental surgeon. She is an alumni of Government Dental College, Mumbai for her undergraduate education. She also has post-graduations in hospital and healthcare management, clinical research, and public health. She has also been associated with National Accreditation Board for Hospitals and Healthcare Centers, that is NABH, and Quality Council of India, QCI, for the past 1 decade in various capacities as a principal assessor, technical committee member, and faculty for various national level courses for quality standards held by NABH. She is a technical advisor for IDA for quality standards in dental practice. She is a lifetime quality professional for CAHO and a member of the dental division. She is also into private practice for the past 23 years and is the proprietor of Family Dental Care Clinic. In recognition for her work on quality in oral health care, she has been awarded a fellowship by International College of Dentists, that is India, Bangladesh, and Sri Lanka chapter. Ma'am, over to you.
Hello, good afternoon, and I hope all of you have had a good festival weekend. So we'd like to start today's sessions. Okay, so the topic for today is monitoring clinical outcomes in dental practice. I think most of the people who are here today are dentists in some capacity or the other, quality professionals in hospitals, as well as dental surgeons who are either into private practice or as a part of dental colleges. So all of us have one main motto in hand, irrespective of which variety of healthcare we are associated with. We want patient safety and good clinical outcomes. So when we say good clinical outcomes, how do we monitor what we are doing? That is going to be the topic of discussion today. When we evaluate quality of care, we could think of three particular divisions: structure, process, and outcome. So just to give a small brief understanding, if we want to study whether we are evaluating our quality in terms of structure, we will think of physical and organizational characteristics where healthcare occurs. For example, if we are going to a hospital and we visit the ICU, we would like to see the structure of the ICU, that is, how many nurses are appointed per bed. Is the manpower which has been allocated by the management same as what is guided by international standards? That would be evaluating quality of care in terms of structure. When we talk about process, we talk basically of various types of interventions, procedures, diagnostic services, etc., which is done to the patient for curing them or improving their quality of life. So let's take an example of process, since we are all dentists here. Supposing we want to evaluate how many of our restorations have got converted into endodontic treatment because of failure of restoration. That would be studying the process of our treatment. We will have a look and see whether the technique is going wrong, or the methodology is wrong, or whether the materials which we are using are faulty. So we'll have a look at the process and then see whether the healthcare which is delivered to the patients is appropriate and following international guidelines or not. When we talk about outcome, we are basically talking about those aspects of quality of care which affects the healthcare of the patient and of population. Today we are going to talk about outcome indicators. Donabadian in 2005 said a very, very beautiful line which says, outcome measures remain the ultimate validators of the effectiveness of quality of healthcare. A patient doesn't know how many nurses are there to the ICU, or the patient doesn't know what the textbook says about procedure which has been laid down for various treatment modalities, but the patient knows about what the outcome is. So outcome measures are the ultimate validators of the effectiveness of quality of healthcare. Outcome measures reflect the impact on the patient. Outcome measures demonstrate the end result of improvement work. Outcome measures demonstrate whether the aim which has been set has been achieved. For example, we want an aim of reducing adverse incidents. So that is the outcome we expect. We have laid down a process for that, and we want to see if following that process has given us this outcome. Reduced mortality, reduced hospital-acquired infections, better patient experience. These are various aims which could be set, and these are various outcomes which we aim to achieve. What is clinical outcome assessment and what is it used for? So what are clinical outcomes basically? They are changes in health, function, or quality of life that results from healthcare. Clinical outcome assessment is a measure that describes or reflects how a patient feels, functions, or survives. Constant review of our clinical outcome establishes standards against which we can continuously improve all aspects of our practice. So, what are the different types of outcome assessments? Now, if we want to study the outcome which has happened in whatever treatment has been given, we can measure outcomes in 4 ways: patient reported outcome measures, observer reported outcome measures, clinician reported outcome measures, and performance outcome measures. Patient reported outcome measures, obviously, as the term suggests, is reported directly by the patient. Observer reported outcome measures is an observation by any person who is other than the patient or the healthcare provider. Clinician reported outcome measures is reported by a trained healthcare professional. And performance outcome measures are basically the healthcare professional or the doctor, dentist, nurse, whatever, will give a task to the patient to study what outcome comes after the task is performed by the patient. For example, it could be a lung function test, or it could be, like if the patient is asked to do spirometry and you want to see how much of improvement has happened. So that is a performance outcome measure. Interpreting clinical outcomes. The patient-reported outcome data can provide meaningful interpretation. So today we are going to stick to dental topics. So I'm going to give all the examples which are related to our field, that is dentistry. Supposing you have given a patient implant-supported dentures. He comes back to you for follow-up and he says he is able to chew well. He's able to chew his favorite chakli or muruku with his new dentures. So what we interpret that as that the masticatory function has improved after implant supported dentures as opposed to the old dentures which were used by the patient. If you want to interpret clinical outcomes of observer reported measures, this is another example. A small child is undergoing orthodontic treatment. The mother comes to you and says that the child has reduced mouth breathing after the treatment has started. So what does that actually mean? We have done palatal expansion. Palatal expansion has improved nasal ventilation and craniofacial development. This is our interpretation of the clinical outcome which has happened. Clinician reported outcome measure. Patient comes back with severe pain after 3 days after extraction, and clinician reports a dry socket. Actually, in this case, there would be two outcomes which have been reported. One is patient reported, that is pain. The other one would be clinician reported, which is dry socket. These will be two outcomes which we have to note down while we are reporting this particular study. Performance outcome measures. So this is another example. If we want to have a functional assessment test for masticatory performance, we could do, for example, two types of tests. First is biting efficiency test. We check the size of the food particles after 20 chews before and after the prosthesis. Supposing you check before the patient is wearing the new denture, what is the size of the food particle? And after he wears the dentures, what is the size of the food particle? We can assess whether the masticatory performance is improved. Similarly, mixing ability. You give the patient two chewing gums. Ask them to chew on the chewing gums before. Give another fresh two chewing gums to the patient. Ask them to chew after for the same amount of time. And when you study the chewing gum, you will know whether there has been homogeneity in color or some parts are being more chewed, less chewed. So you will have an idea. So these are performance outcome measures. How well do clinical outcomes address patient concerns? See, at the end of the day, it is patients' concerns which are most important to us. So patient could have four types of concerns. First is they could have disease-related symptoms. For example, suppose the patient comes to us with a swelling, which is related to a decayed tooth. Then he could have that kind of symptom. Or there could be a concern about functional status. For example, the patient says he is not able to chew well at all. After the treatment, the chewing ability improves. The third type of concern which the patient could have could be quality of life. Several times patients come to us and they say that, they are not able to smile because their teeth are very ugly. Once you do cosmetic correction, their psychological quality of life improves. So that could be one concern which could be addressed. Therapeutic quality, again, like we said before, if you replace a tooth, the masticatory function will improve. The fourth type of concern could be treatment tolerability. For example, supposing there is a parent of a special child who needs to undergo endodontic treatment. The child may not be able to tolerate local anesthesia or cooperate under local anesthesia. So in these cases, that particular aspect has to be kept in mind. So that is a concern of the patient. How do you measure clinical outcomes? We have been talking about this for so long, but how exactly do you measure it? So measurement can be of three types. Either you can measure it at one single point of time. Patient comes to you for one consultation. You have a look at it, patient's health status, health quality of life, you measure at that time. You could measure outcomes of specific interventions. For example, before endodontic treatment, after endodontic treatment. So second and third point are somewhat similar. Basically, you do specific interventions and you see the outcome of that. That is the second point. And the third point, you see it at two different points of time. That is before versus after. So now we are just going to compare what could be the pros and cons of patient-reported outcome measures as opposed to clinician-reported outcome measures. The advantage of patient-reported outcome measures is that it is inexpensive. You could just give a feedback form where the patient could fill what his experience has been, or we could take a video and share their experience. That captures the patient's experience. Now, when you get a form like feedback measure, you could enter it into the computer and you could get proper algorithmic assessment. What are the cons? One thing is high respondent burden. We have to be sure that the respondent is going to give proper answers. Variability in response, low responses. These are some cons of patient-reported outcome measures. If we think about clinician-reported outcome measures, they also have some advantages and disadvantages. Advantages are that it is a standardized activity and setting because clinicians are trained in a certain way. So it will be a standardized activity and the place where it is being measured will be standardized. Summative assessment by the clinician, again, because of training. The cons are rater bias and doesn't capture patient experience. We could have a bias. There are many clinicians who will feel, oh, I have done the best possible work. So they could be biased about giving a score to their own kind of outcome. But today's topic, we are basically going to talk about clinician-reported outcome assessments. Clinician-reported outcome measures are evaluations in which member of investigating team who is the rater has appropriate professional clinical training. That is, it could be a doctor or a dentist or a nursing professional. So they are the people who will report outcome assessments. What are the types of clinician-reported outcome assessments? We could have three types: readings, ratings, and clinical global assessments. What are readings? Readings are very simple. They are those evaluations which are in yes or no form, dichotomous forms. For example, radiographic evidence of fractured root piece or radiographic evidence of a missed canal after obturation. Yes or no? Is it present? Is it absent? Ratings are basically evaluations where you would have a scale. For example, if the characteristics are reported in at least 3 categories, which will generate scores, that is a rating. For example, pain scale or health scale for dental implants. The third type of clinician reported assessment would be clinical global assessment. So these, very often happen because clinicians, they use their instinct several times for certain types of assessments for an overall judgment of the patient's health status. For example, there are some cases, for example, supposing the patient has a hospital acquired infection or antimicrobial resistant infection. There are times when the clinician uses his judgment and decides that certain combination of drug can be tried out to see if it is working on the patient. So that sometimes is not always very specifically written down. It is by the judgment of the clinician. So that is clinical global assessment. So when we do a clinical outcome assessment, these are the various steps to follow. I will be explaining each and every one of these, and I will also be giving examples at the end of it so that we know how to carry out a clinical assessment in our practice. So the first thing is we define the context of use of the clinician responders outcome assessment. We choose the intended treatment benefit. We identify the concept of interest to be measured. We evaluate the relationship between treatment benefit and concept of interest. We document content validity. We evaluate other measurement properties of ClinRO. We define the endpoint of the study. We establish interpretation and evaluate operational considerations. This is the entire flow chart. I will be going through this one by one. First thing is defining the context of use. When we take up a particular outcome assessment, we will think of what disease are we covering exactly? Which is the demography of the population we are looking at? Are they pediatric patients? Are they geriatric patients? What is the severity of disease we are looking at? Is there any history of previous treatment for this? Then when the clinical assessment design which we do will have an endpoint definition. We have a study setting. We decide whether we are going to look for these outcome assessments in inpatients or are we going to look for them in outpatients? Are we going to look for them in urban or rural settings? Then we will define an endpoint and evaluate the treatment benefit according to the context of use. So this was about context of use. Next thing is you have to choose what is the intended treatment benefit. For example, you will choose it with respect to patient's feeling, function, and quality of life. For example, if the patient, your outcome which you want, that is intended treatment benefit you want, should be decreased symptoms of pain and swelling, improving chewing ability for function, and better psychological quality due to cosmetic smile correction, that is for quality of life. These are just 3 examples which you could decide is your intended treatment benefit. Next is concept of interest. Basically, what is concept of interest? It is what the clinician is going to measure in the assessment. What exactly are you going to measure? Are you going to measure pain scale? Are you going to measure the swelling size reduction? Are you going to measure the reduction in tooth mobility? What exactly is the clinician measuring? That is the concept of interest. Evaluating relation between concept of interest and treatment benefit. Now, when you're measuring all this, it's not just a theoretical thing. We have to see the interrelationship between all these steps. For example, supposing we do oral prophylaxis or scaling, and we see that there has been great improvement in gingival inflammation and suppuration. But the patient's concern originally was that there is tooth mobility, and the tooth mobility continues to exist. So this outcome measure gives an insight that further interventions like periodontal surgery could be needed. That is the relationship between concept of interest and treatment benefit in this case. Next is elements to document content validity. We have a summary of literature review of concept protocol. So these are all basically evidence-based dentistry, which we will follow according to international guidelines. And we'll decide according to literature review, according to methods, results, protocols, what will be our inclusion and exclusion criteria. Then whether the patient is able to understand what the instructions are, which are relevant to the assessment. Other measurement properties will be evaluated. For example, we will consider certain confounding factors like inter-rater and intra-rater variability. Then we define an endpoint. After keeping all these things in mind, we will define an endpoint. Now, the definition of endpoint should keep certain things in mind. You should also keep in mind the objectivity of clinical global assessment. We just talked about that, about the instinct of the clinician. Now, sometimes the instinct of the clinician cannot be very objective. So we have to just think whether are we going to consider something as subjective as an instinct as a part of our assessment. Then inter-rater variability. We'll think of various raters. Supposing there are multiple clinicians in a department, there could be variability in the way they are assessing the outcome. So those points have to be kept in mind when we are defining the endpoint and analyzing the result. After that, we will establish the interpretation. Interpretation of results of outcome assessment should evaluate whether those differences, whatever we have seen in that outcome, is meaningful to patients. And ultimately, it is that the patient should be comfortable and they should have some improvement after whatever intervention or treatment has been done on the patient. Also, we will evaluate operational considerations. After doing this assessment, suppose we see that certain clinicians need training or certain protocol needs standardization, or if there are certain operational barriers, all these have to be kept in mind, and corrective and preventive action for the above have to be done. So this was all about the theory of what this is exactly. So we will take an example now. So this is the first example we have taken where our basic outcome assessment is going to be regarding repeated class 2 restorations in pediatric patients in the OPD of a pediatric clinic. So the context of use was population was pediatric, then the setting was OPD in a pediatric clinic, and what we are studying basically is repeated class 2 restorations. Again and again, class 2 restoration is fracturing and the patient is coming back. Then you choose the intended treatment benefit for the patient. Every time the filling breaks, the child is unable to chew and is having pain. So the intended treatment benefit is to decrease the pain due to the broken filling and improved chewing. Next thing is you identify the concept of interest to be measured. What is the concept of interest? Basically, what is the clinician measuring? Clinician is measuring which is the area where the fracture is happening, which is the material which is being used for the filling, what is the technique of the filling. That will be the concept of interest. Then you evaluate the relationship between treatment benefit and concept of interest. Basically, you want to see, supposing you measure these concepts of interest, whether it is giving any benefit to the patient. Does the change in technique or change in filling material or improvement in patient communication, is it improving the patient health? That is what you want to see, the relationship. Next is documenting content validity. Basically, you have to see international percentages of fractured fillings. What is the acceptable rate where fillings fracture internationally? What is the evidence-based methodology in practice? Are we following the right technique? What is the evidence-based practice for it? What is the patient's understanding of instruction? Sometimes, they are children and, they don't listen to us properly. You tell them don't chew anything for an hour and they'll go home exactly in 15 minutes. They'll go and chew exactly from that side. That could be, lack of understanding by the patient. Evaluate other measurement properties. Intra-clinic clinician variability. Like I said, there could be other, clinicians who are working in the same department, and there could be variability in measurement of outcome. Also, post-op instructions. Have they been documented, whether it has been given or not to the patient? Has it been implemented? That has to be evaluated. Then you define what is the endpoint of study. What is your endpoint is very clear. You want reduction of fractured class 2 restorations. Then you establish an interpretation. You analyze it. Now, this is basically the thing which you are going to do. These are called quality clinical indicators. You have to basically see the number of patients who have fractured fillings in a month divided by total number of patients who have been treated in that month into 100. By this, you get a percentage of patients who have come back with fractured fillings. Now, then what do? You have to interpret it. You have to compare it with international standards. After that, and you also have to do the analysis which was mentioned earlier. What is the area of fracture? What was the material used for filling? What was the technique used for filling? Whether it is one particular clinician who's fracturing his fillings again and again, that type of thing. Then you have to see that whether this type of study is improving the patient's health quality and function. You have to interpret that and evaluate operational consideration. Whether there are some staff members who need training. Is it that substandard quality of materials are coming in? Whether communication improvement has to happen with the patient. So this will be the entire study of the problem in hand, that is repeated class 2 restorations in pediatric patients. So while this is for understanding, what we actually have to do is we just have to see how many patients are coming with a fractured filling in a month, divided by total number of patients treated into 100. You come across a number, you see whether that number, how it compares to international standards. And if it is very poor, then you have to analyze, find out the root cause as to why this is happening, and try to implement corrective and preventive actions. That is the whole reason for doing these outcome assessments. Giving another example of surgical site infection. First, we define the context of use. What is the context of use? Post-operative infections after dental implants before prosthetic loading. So this was our context. That is, it has to be patients who have received dental implants, it has to be post-op infections, and it has to be before prosthetic loading. Next thing is you wanted to see the intended treatment benefit. What is the intended treatment benefit? There should be reduction in pain, swelling, pus, and implant mobility. Then you identify the concept of interest to be measured. What exactly will the clinician measure? You will measure infection according to international guidelines, whether there is pain, swelling, purulent drainage, etc. Then you will evaluate the relationship between treatment benefit and concept of interest. Here, what are we going to see? We gave antimicrobials. So by giving antimicrobials, has that particular treatment improved the concept of interest, that is improved the infection which is there, and what is the relationship between that? Then you document content validity, that is scientific literature for international failure rates, then international infection rates, then patient communication, whether it has been proper. Then you evaluate other measurement properties. Like for example, there'll be several confounding factors, like patient could be having certain deleterious habits like smoking, depending on the type of implant which is used. Then there could be comorbidities like diabetes. All these things could be confounding factors in your measurement. Then you decide the endpoint of study. The endpoint of study is reduction of post-operative post-operative infections after dental implants. Then you establish an interpretation. First, you do the analysis. That is the indicator. Which is the indicator? Number of surgical site infections in implants divided by total number of implant surgeries into 100. Then you have to see whether the treatment protocol has improved the patient benefit. You evaluate operational considerations, whether the clinician's training is okay, whether the technique they're using is okay, whether the material they're using is okay. And that will be the way you study implant surgical site infection. So this was another example which was given regarding outcome measurements. So these are certain KPIs, key performance indicators, which have to be monitored in dental practice according to the new NABH third edition for dental surgeons. So for dental practices, this is not the entry level one. This is for the complete NABH assessment for hospitals as well as clinics. So here they have given about 15 indicators which have to be definitely monitored. These are called core requirements. So out of that, you have incidence of medication errors, that is number of incidences by number of opportunities into 100. These have to be monitored monthly. Then you have surgical site infections. They have said only for hospitals it is mandatory. Otherwise, it is optional. Then hand hygiene compliance, prophylactic antibiotics. They have to have a certain kind of protocol as to when they give prophylactic antibiotics, and whenever it is mandated, whether those patients are receiving it divided by the total number of patients who underwent surgeries into 100. This has to be monitored monthly. Similarly, waiting time in OPD, number of sharp injuries, they have 15 such indicators which they have said have to be monitored. Number of X-ray redos, monitoring of prevention protocol for adverse events like wrong site, wrong patient, wrong surgery. So this indicator is basically an indicator for monitoring how many cases where procedure was followed by total number of surgeries into 100. Then number of variations in mock drills, dental equipment downtime, OPD satisfaction index, sentinel event indicator, incidence of blood body fluid exposure, percentage of incomplete records, and employee satisfaction index. These are 15 core KPIs which NABH has given. But as we all know, this is not the end of the story, because to achieve excellence, you have to monitor more number of indicators, especially if you are a hospital. So how do we do that? Since I'm taking this topic today, I would like to just give a few suggestions. Like each department should basically identify 5 most commonly done procedures in that particular department. So you see which are the 5 most commonly done procedures, and you have indicators for those 5 procedures. That would be an easy way to do it. So certain examples I have just taken. Here I have not only talked about outcome indicators, because this topic was only on outcome indicators, but since we have to monitor all indicators, I have just listed them. Out of these, whatever is implementable by your department, by your hospital, and by your practice can be followed. If it is a small dental practice of a clinic, those 15 indicators which NABH has said has to be monitored as core is sufficient for a start. So the first example is percentage of dental restorations which had to be repeated in the last 3 months, percentage of restorations which resulted in endodontic treatment in the last 1 year, percentage of pit and fissure sealants which had to be redone, percentage of reduction of number of new carious lesions in deciduous teeth per child in the last year. So all these for the Department of Conservative Dentistry and Operative Dentistry. Percentage, now these are again for pediatrics, we can look at this. Percentage of children less than 18 years who underwent fluoride varnish, percentage of children aged 13 years with unerupted canines. This could be for pedo department. Then for oral surgery, you could have percentage of dry sockets in the past month, percentage of tooth fractures during extraction, percentage of alveolar bone fracture during extraction, percentage of surgical site infection in implant surgeries, percentage of surgical site infection in oral surgeries. Then in endo, you could also have percentage of instrument separation, percentage of endodontic treatment which needed retreatment, percentage of endodontic treatment, endodontic cases which needed extraction, percentage of implant failures. Then in prostho, we could have denture redos, crown and bridge redos. In oral medicine and radiology, we could have percentage of X-ray redos, cone cutting defects of X-rays, image magnification. In ortho department, we could have relapse, an indicator on relapse. Then apart from that, as a general indicator for medication safety, we could have percentage of adverse drug reactions, local anesthesia adverse effects. Then for pathology, we could have delayed reporting, that the turnaround time TAT has not been followed, percentage of medical emergencies in the past year. These could be some examples of clinical indicators by various departments. Also, we have managerial indicators, like for example, percentage of delayed procurement of dental materials, percentage of non-utilized space, equipment and manpower, percentage of patients who had increased waiting time, percentage of satisfied patients, percentage of satisfied employees, percentage of OPD conversion, that is consultations which resulted in treatment, percentage of profit, percentage of hours of seeing patients to open time in OPD, percentage of case acceptance, percentage of collection which received to the collections expected, that is fees, many times they don't pay. So you can find that out. Percentage of cancelled appointments, percentage of new patients. These could be some KPIs which we could follow. Percentage of overheads in the last quarter to collections. Then percentage of major risks found in facility rounds, adverse events, a percentage of BDS to MDS staff, percentage of clinical chairside assistants to dental surgeons, percentage of employee attrition, percentage of emergency medicines which had expired, percentage of data collection for quality enhancement program, etc. So thank you for listening. If the treatment was done in the previous month and failure is in this month, yeah, so the thing is, you have to follow international guidelines and see what is the time frame you're going to take for reporting failure. For example, the example which I gave is before prosthetic loading. So any time before prosthetic loading, if there is a problem in the implant surgery, then it is regarded as a failure. So that is one point. Where can we find the benchmark for dental measures? Okay, so these are, you have to look at various sites. For example, for infection control, you have to look at CDC guidelines. For certain things, even our Indian government, no, they have given certain guidelines. You can follow those depending on what topic and what kind of benchmark you are looking at. For patient-centered
Good
care.
evening, ma'am.
Yes, yes. Good evening.
Ma'am, I'm Dr. Bhavani, ma'am.
Yes, Dr.
Nice presentation, ma'am. It's very informative. So
Thank
I
you.
had a small query, ma'am.
Yeah.
So for example, GIC fillings are there.
Yeah.
So in the month of June, I have done, department has done 10 GIC fillings. Right, ma'am?
Okay.
And July, May, same, where the GIC filling was done in June, in July, the case has done, means there is some fracture or something. So
Okay.
as per the quality indicator, the percentage of failures into 100 by total number of cases done in that month. But actual treatment was done in June. But the case has come in July.
No, but then it
Treatment
will be
failure.
considered as the month of June. The denominator will be month of June only, even if the patient has come back in July.
So, okay, ma'am. So if we
For
have to give
example,
that,
just one
ma'am.
small example. Supposing you did 100 fillings in the month of June. Out
Yes,
of
ma'am.
that, 20 patients came back. Some came in August, some came in July, some came in September.
Okay.
They will still be considered for the month of June only. They will not be considered for the month they have come back in.
Okay. So if it is something that if we maintain the register, so when we have to fill the register, it's not monthly register. We have to complete that calculations, ma'am.
No, so you have to do it monthly only. But if it's an
Yes.
ongoing process, no, then usually these indicators are calculated quarterly. See, there is one
Quarter,
thing you
3
have to
months.
basically keep
Okay.
the register and analyze it and review it monthly. But the final calculations are done quarterly.
Okay. Okay, ma'am. Okay. Thank you very
Okay.
much, ma'am. Thank you.
This is a very genuine question they were asking because we also have issues with quality indicator assessments. The same
Yes.
doubts even I was having, ma'am. Because
Yeah.
there will be some event that you would have done or some procedure you would have done some month and some other month actually the failure or there is a problem. How do we actually put it across is a question. Actually, it's very genuine, especially you are
Yeah.
having clinics with NABH accreditation and following quality indicators. It is a good question, ma'am. It will be nice if you can I mean, whatever you have told, and if there's anything else that we can follow.
So there is one this new standards which have come for NABH. No, they have a appendix in the end. If you people can just take a little time out and read that appendix, each and every quality indicator has been explained with an interpretation. The same doubts, what happens if they come after 1 month. They've even given one example, month of December, November. Just go through that; it will clarify your issues. And if we have any other further queries on it, we can take it up even later. I'll be happy to answer it.
Thank you, ma'am.
Yeah. Any other questions? Okay, so somebody has Asia has said, for patient-centered care, will PROM be beneficial or clinician-reported be beneficial? See, all our care, Dr. Asia, is going to be patient-centered only. We are, as clinicians, we like to look at textbook pictures. We like to look at obturations which look like what's given in the book. But at the end of the day, all that we are doing is for patient-centered care only. So PROM is very beneficial in many ways, and clinician reported is also beneficial in many ways. So in my opinion, both should be a good, mix of both things will be a good way to evaluate our practice. Anybody else, please?
Good evening,
Incident
ma'am.
reporting should also be filled for near miss. Yes, it should be for near miss as well. Yes. So near miss is, for example, for those who are not clear about it. For example, supposing your, patient, your assistant, dental assistant, has filled one injection syringe with local anesthesia and another injection syringe with hypochlorite. And while handing it to you, he gives you the hypochlorite instead of local anesthesia. But before injecting it, you have realized that this is hypochlorite with the smell and you discard that syringe away. So that is a near miss. So these should also be recorded for incident reporting. Yes. And by the way, the new NABH standards have also given incident reporting forms. You can have a look at that section also. That is in Appendix 2. You can have a look at those points as to how to report incident, what are the incidents to be reported, and what all should be filled.
Ma'am, this is the third edition that you're talking about?
Yes, third edition.
Okay, okay, ma'am.
Yeah. Anyone else?
Good evening, ma'am. I'm Dr. Krishna Kumar.
Oh, hello, Dr. Krishna Kumar, and congratulations, first of all.
Now, thank you. Thank you, ma'am.
Dr. Krishna Kumar has got the first prize in Kerala State for biomedical waste segregation recently. For
Yes.
all of us who know him, it's a very proud milestone. Yes, doctor, you're saying something.
Yes. What's the meaning of unutilized space, ma'am?
Unutilized space is dead space. For example, you have these kind of corridors. Supposing you have a setup of say 1,000 square feet of space,
Okay.
and you have these corridor areas which have not been utilized. It is just for better utilization of your own infrastructure. It is not an indicator which is definitely mandated. Definitely not.
Okay. And what's the ratio of chair to assisting staff, ma'am?
Ratio of you're asking about space requirement?
No, no, no.
Huh.
The chair ratio of dental
Oh, okay,
chair to
okay.
assisting staff.
How many assistants per
Yes.
chair? You're asking that?
Yeah. Yeah.
Okay. So now we have to first see, whether we are asking about a legal standpoint or whether you are asking about, your own quality standpoint. If it is a legal standpoint, then today in India, the prescription is only one assistant for one chair, because there are many small places where people can't afford it. But when you're looking for your own standpoint, I would recommend, it should be 600 dentistry with 2 assistants for every dentist. But that is not something which people can follow everywhere.
Okay. Madam, regarding the assistants, the attrition ratio is more.
Very high. Yeah, I know.
Yes.
I know.
The more we train, and a lot of them go off.
I know. That's always the case.
They are being offered higher job, salaries. So we have a problem with that.
I know.
Yes.
In fact, Dr. Krishna Kumar, you are actually one of the lucky ones, because Kerala has got very good assistants.
Yes, of course.
But if you look at other states, they have, even more of a challenge when it comes to these things.
Yes, ma'am.
Yeah.
Okay, ma'am. That's it from me. And thank you very much for all your wishes. Thank you, ma'am. Thank you.
Best wishes. Yeah. Anyone else? Would you like to ask any other questions? Okay, I think Dr. Nithin, we are done. Most of our questions have been answered. Is there something else which you would like to add?
Ma'am, one more question has come across, ma'am. Something regarding radiation safety.
Radiation safety require. I have not understood the question, please. Is it possible to unmute her? Radiation safety required? Yes, it is required. But I don't know what the question exactly means.
Yeah.
Ma'am, she can talk, ma'am.
Yeah.
Yeah, hello, ma'am. I just wanted to know whether, do we need a radiation safety officer?
Do you need a radiation safety officer?
Yes, ma'am, for a dental clinic to be assessed.
For a dental clinic, you're asking,
Yes,
or
yes.
for dental college?
For dental clinic, madam. For a dental clinic, do we need a radiation safety officer?
No, you yourself will be the radiation safety officer.
Okay.
Your clinic.
Okay.
You don't need a separate RSO for this.
Okay.
Yeah. But you will have to have your equipment evaluated according to AERB guidelines and get the QC from time to time.
Okay.
That they will send their RSO to do it if required at any point of time. But otherwise, for a small dental clinic, you are the RSO. You don't need a separate RSO.
Okay. Thank you.
Yeah. Okay, I think we are done. I don't think there are any more questions.
Yes, ma'am, just to let the others know that a feedback form has actually popped out. I request all the participants to kindly fill in the form and send it across. So we'll be able to know what exactly was good and what needs to be, improved. Definitely, ma'am, you did an amazing job, but still, nonetheless, we would want this feedback.
Yes, there's always scope for improvement, and we'll be happy to hear your feedback. Thank you so much.
Thank you so much, madam. Dr. Rajesh here.
Hello, Dr. Rajesh. How are you?
Yeah, fine, madam. Fine. How are you?
Fine. I'm happy you liked the session. I hope it was informative.
Yeah, of course. It was very much informative.
Okay.
I never thought there were 25 clinical indicators and 20 manager indicators also. With the key indicators.
Okay. Let me clarify, Dr. Rajesh. That is a list made by me. It's my personal list. It is not prescribed by NABH. NABH has given their 15 indicators in the end of their book.
Exactly. Yeah.
Okay.
Thank you, madam. Thank you.
I hope we'll be able to get a copy of presentation. I'm not sure about that, Dr. Elizabeth. Maybe you can ask CAHO staff. I'm not very sure about that. Okay, Dr. Nithin, I think we can conclude our session for today.
Yeah. Ma'am, thank you for a very informative session. There were a lot of, as the previous person was actually telling, there were a lot of those indicators that you mentioned that even I had not seen. Ma'am, it would be nice if you can just put it across one more time. Probably if somebody wants to take a screenshot, they could do it.
You want me to share the screen again?
Yes, ma'am. In case CAHO will not be able to give it to us.
Yeah, I will
Maybe
do that.
It will help the others.
I will do that, but the first 15 indicators which is given is there in the NABH book. I'll give you the ones which I have made.
Ma'am, yes, ma'am, because there are some extra ones that you're prepared.
Yeah, the ones which I have put are all my own list. It is nothing to do with NABH. It's just for your own interest. If you want, I can put it up.
Yes, ma'am. Please, could you do that?
Okay, sure.
Ma'am, you can share your presentation with us, ma'am. We will share with the participants.
Okay. So,
Okay, very good then.
okay. So since CAHO has clarified that, I don't think I need to share the screen now. I think
Yes, ma'am. Yes,
they'll
ma'am.
send the entire presentation.
Yes,
Yeah.
ma'am.
So what I'll do is I'll just send this presentation to Dr. Arjun. Maybe he can forward it to CAHO and they can pass it on to the participants. Will that be?
Surely, ma'am.
Yeah. Okay.
Ma'am, thank you so much for an
Thank
amazing
you.
presentation.
And we
Hope we
had a
meet more,
wonderful
ma'am.
audience. And thank you, Dr. Nithin, for being such a lovely moderator. And
Thank you so much, ma'am.
yeah, thank you very much.